Thank you very much, Dr. Ankur. Good evening, everyone. After a long time, I'm back at the dais of among the PRS colleagues, respected seniors and my dear colleagues. So we'll be discussing today about the substance abuse. So far, so near. So what actually substance abuse is? It refers to the harmful or hazardous use of the substance and for non-medical purpose, usually recreational purpose. And if we go through the types, what kind of substance are included in this, then it's opioid, that is what we call caffeine, it is synthetic or natural, illicit cocaine, marijuana, or marijuana, how we pronounce it. Prescription drugs like again opioids or benzodiazepines, stimulants like amphetamines, alcohol, again this is the most common substance which is being abused, and tobacco. Yes, tobacco is also is included as a part of the substance abuse. So let me be very clear, I'm not a social worker, I'm not a psychiatrist, I am actually intensivist, and so our talk will be limited to the intensive care management and ICU management of the substance abuse. So usually this is American data in 2011, from 2011, it says that commonly the substance which involves are the sedatives, just a second, are sedatives and antidepressant and cleaning substance and cardiovascular drugs and alcohols are the common substances which are being presented in hospital. So we also have Indian data which says that after organophosphorus compound and pesticides, the most common poison which are presented in ICU are pharmacological substance and the substance abuse. That is almost like 37%. So we always learn about something about OP poisoning and aluminum phosphate, but it's the substance abuse in ICU is the one category which is much important, and also it is evolving. These are the real data from government. The magnitude of substance abuse, almost 14% or almost like 15% of these are again, just see, they are government data, not private data. So government data says 50% of the population are with alcohol's abuse, 3% with cannabis, and cannabis again a part of marijuana or bhang. Opioids offend 2%, sedatives 1.1, and this is from 2019. So this is 2015. Again, as I said, the substance abuse is evolving. So it is the real threat, and probably they are not talking about it. Let us discuss one patient which we had. This is one patient presented to us in emergency ward, intubated in other hospital. He presented there in respiratory failure. He was intubated. He presented to us in unconscious state. At a room on Ambu bed, and then Ambu bed his saturation was somewhere around 80. His he was found unconscious with the pool of vomiting. He was found unconscious with the pool of vomiting, and then was brought to the hospital. On examination, we can see that he is. Can I have a pointer? First, you have a pointer? Just take this show. It's okay. We can see here the blood pressure in the third category. You can see blood pressure was around 100. He was his situation was 84 at room temperature, and he was diagnosed there at primary care hospital peripheral ICU as a parapet poisoning. And then he presented to us immediately after stabilizing. We shifted him to ICU. This is a representation image, and he was being settled there And what everyone thought based on his oxygenation and then it was a paraquat poisoning. We all know paraquat poisoning practically is lethal, and the same GC was conveyed to the relatives and everyone. Interesting to note what he was having was this greenish blue discoloration of the urine, which is consistent with the paraquat poisoning, not specific to but consistent. Other causes of this type of greenish blue discoloration is amitriptyline, dye ingestion or methylene blue. So it can be seen in other, but everything was confirmed. And as soon as we received the patient, initially we started with our routine treatment with antibiotics, steroids, because there are evidence that steroids may help. So all the heroic efforts are futile if in case of paraquat poisoning, unless and until the consumption is very low. We started with vitamin C, and immediately what we planned was that DLC catheterization and arterial line was done, and we planned to go for hemoperfusion with this charcoal hemoperfusion with the charcoal filter. So this is what we planned, and we say to the relatives that probably he is not going to make out. Coming to his investigations, his hematology reports are normal except for mild leukocytosis. His serology was negative. His population profile was good. Cholinesterase to rule out OP was organophosphorus was also normal, and his electrolytes were normal. His urine analysis was unremarkable. At the same time, we also sent urine for toxicology, because we had faint history that he was sometimes he used to consume some kind of drugs. He was very known case of psychiatric illness. Sometimes he used to take medicine, sometimes not. He was also diabetic and hypertensive. He was 44 years old. Vital organ function test as far as concerned, creatinine was high. Again, our suspicions for paraquat poisoning are slightly high, and his liver, except for the rise in SGOT, was normal. CRP was 51, again moderately elevated. His initial ABG showed PO2 of 68.7. Again, he was kept at room 21% of FiO2. We have not increased FiO2 because in paraquat poisoning, even a slight amount of oxygenation leads to the accelerated fibrosis of the lung. So his O2 was kept at 21%. And subsequent ABG, if we can look at the PO2, his PO2 was slowly decreasing. His PO2 was slowly decreasing. So again, we were very confident that this is paraquat poisoning, and probably he is not going to survive. The way he presented, he was not going to survive. This is the third day. Slowly he was getting stabilized, but one specific thing occurred, which is blood pressure was shooting like anything. The last night it was shooting, and this is the morning vitals. It was 230, and it has reached to 280. In fact, his urine output was good after dialysis, hemoperfusion, and again he was on basic antibiotics. So at this level we plan for his blood pressure management. And you can see NTG, Lobat, isolazine, beta blocker, camine, amlodipine, all are going. Tell me certain one. ARB was not used because he was having AKI. And slowly we can see that after the initial BP shoots up. This is BP recording of our nursing chart. And slowly he stabilized, and finally he went all right. And he stabilized. By fourth day he was good hemodynamically. Our urine toxicology analysis came suggestive of benzodiazepines poisoning and marijuana, that is trihydrocannabinoid, that is marijuana or marijuana, whatever we call. So these two were present, but still this thing does not explain everything what was going on, except for the hypertension, probably because of the increased use of marijuana or cannabis. But this was the patient, and so how actually we manage ODs, that is overdose in ICU. Let us have some profiling of this kind of patients. So who are they? They are broken people. They are, have some sort of psychiatric illness. Their social history is slightly doubtful. We can understand broken marriage and everything. They are the party lovers. They are party people. This is what they are. These are the celebrities, the party lover celebrities, or the famous people who had OD'd and died, right from the Elvis Presley to Marilyn Monroe, Michael Jackson. Everybody died because of the OD. And what I said right from the beginning there, this OD or the drug abuse is far more common and it is more lethal than what we think. These people have suicidal tendencies, they are accident prone, so a lot of things is going on. One thing to understand that usually with these drugs, the single therapeutic dose, if it is less than 10 times the normal therapeutic dose, then usually they are not life-threatening. But if more than that, then they should be referred to the ICUs, and usually life-threatening manifestation occur within 6 hours of ingestion. So the early period is very much crucial. Having a basic outline of what we do normally in such kind of patients is that we maintain ABCs, everybody know what is it, assess the level of consciousness, give antidote if indicated, prevent absorption, drug analysis requested, what we did, increase elimination of poison, and we observe them, we monitor them, and continue care to be given. This is the basic outline. So what we said that we maintain the ABCs initially. Now coming to this opiate, opiate-induced non-cardiogenic pulmonary edema is not uncommon, and you can find when with opiate overdose, we do have 2 patients like this presented with severe pulmonary edema flowing from the mouth, and the lung is having non-cardiogenic pulmonary edema, needs to be ventilated, put on ventilator. And usually they, if timely managed, they do well in the future unless they continue to go for their addictions. In cocaine, cracked lung in the case of cocaine represented by fever, hypoxemia, hemoptysis, pulmonary edema, diffuse alveolar hemorrhage, and severe bronchospasm. So again, these patients after cocaine overdose require immediate medical treatment and probably need ICU and ventilator. Quetiapine, which is again very common. Quetiapine, we use it nowadays. Psychiatrists use it very commonly, and it causes prolonged QT interval and arrhythmia and cardiac arrest. Now there is significant role of sodium bicarbonate in this QT syndrome, and because of its so-called membrane stabilizing effect, they do help in preventing or reverting the cardiotoxic manifestation of this substance. And the usual dose is 1 to 2 ampoules. Each ampoule contains 30 milliequivalent, 30 to 50 milliequivalent. So 1 to 2 ampoules, 3 to 4 hourly, usually up to 2 or 3 days. Also to note that role of hypertonic saline. Hypertonic saline in a straight flush dose is up to 300 to 500 ml is also recommended, that is 3% sodium, and they are saying that in fact it is more beneficial or has more effective compared to sodium bicarbonate here. Fat emulsion. Same can be used. Fat emulsion, what we have our intralipid, that can be used in the dose of 1.5 ml per kg bolus, then followed by continuous infusion. And again, the intralipid in animal models has in fact shown most membrane stabilizing activity compared to this hypertonic saline. So probably in severe cases, use of intralipid is justifiable. Coma cocktail, use of thiamine, dextrose, naloxone. To a patient, unconscious patient, where you suspect drug abuse or drug overdose is logical, safe, and inexpensive. Though it is not well supported by the literature, but it is safe to use it. And flumazenil should be considered if you suspect benzodiazepines. Coming to the point of preventing absorption, how we can prevent the absorption. So, gastric lavage is the method. And usually gastric lavage should be considered only within 1 hour of ingestion, and there is no evidence of benefit even in this situation. So we used to, even after patient present after 2 or 3 days, we continue doing gastric lavage, and that is in fact is harmful. A patient can get aspiration pneumonia, and induced emesis, which we used to practice in past, is no longer recommended for any adult or pediatric person. Activated charcoal, again same, activated charcoal can be used, but it gives the good result only if it is used within 1 hour of ingestion. So don't rush to find activated charcoal. We have seen people who are giving phone calls for activated charcoal, whether it is available, but after 1 hour practically it is of no use. And we have a meta-analysis where it suggests that even within first hour of ingestion, activated charcoal probably does not help. So this is the situation. Whole bore irrigation, we can use peg for whole bore irrigation, but usually it is not effective. However, it can be useful in case of slow release poisons like lithium or iron, or it can be useful in sustained release preparation. If patient has taken sustained release, then probably it can be useful. But again, it was not significantly, statistically significant. The studies prove it wrong that whole bore irrigation anywhere is useful. Coming to the point of increased elimination, how can we eliminate? Urine alkalization is gold standard technique by giving soda bicarb. Usually it is helpful in salicylate and maybe methotrexate and maybe in herbicide, as we suspect in this patient, that is paraquat poisoning. And forced diuresis usually should be abandoned and should not be used normally. There is a position paper on urine alkalization which suggests that there is no evidence of increased risk if urine alkalization is performed. So probably this is safe to perform and can be given a chance, as it is considered to be little safer. Hemodialysis in fact is the method of choice if you want to eliminate toxins. And considering intermittent hemodialysis versus CRRT is probably considered safe in case of hemodynamically unstable patient and very critical patient. So dialysis usually is indicated for salicylate, lithium, alcohol, methanol poisoning, that is the Hooch poisoning, or what we call, and metformin. In others, the role is yet to be established. And as I said that CRRT is attractive, it is attractive in ICU patient, and even in methanol poisoning, we can see that the elimination is quite smoother compared to hemodialysis, and hence whenever possible, if budget or everything permits, it should be instituted. Charcoal hemoperfusion, it is being tried in paraquat, as we started with for this patient paraquat, carbamazepine and phenytoin and theophylline toxicity. But usually their ability has never been proven, and but still there are few of the data from South India which says that paraquat poisoning, charcoal hemoperfusion may lead to improved outcome, but it has never been officially proven. But still we do it. The plasmapheresis is an exchange blood transfusion not to be done. ECMO, the purpose of ECMO is to take over the heart function until recovery, and to support the heart, support the lungs and organ perfusion, and until the elimination of the toxins occur, we need to keep the patient survive. So this is the basic idea of ECMO. And in the few of the things like beta blocker poisoning, CCB poisoning, and sodium channel blockers, in fact, it has given some wonderful result, and it has definitely mortality benefit. So where something is not working, everything is not working with the substance abuse, ECMO is the practically final answer. Now coming to some specific management of common poisoning in very short, if we say opioids, then activated charcoal, yes, within 1 hour, sodium bicarbonate, yes, and antidote is naloxone. Naloxone, before giving naloxone, you need to secure respiration, must be intubated and on ventilator, and start giving 0.5 mg of naloxone. After observing 2-3 minutes, increase the dose by 2, then by 4, then by 10, and by 15. Total 32 mg can be given after every 2-3 minutes, and by then the reversal should occur. With the benzodiazepines, activated charcoal, yes, soda bicarb, maybe antidote is flumazenil, we all know. Now, one thing very important to understand is that with benzodiazepines, we have a obstructive apnea which occurs. This is respiratory cycle, and here we can see that they get a obstructive apnea. So, once you intubate the patient, the obstructive apnea, just intubation, not the ventilation. When you intubate the patient, the obstructive apnea significantly decrease. So, it has been recommended that whenever you have a benzodiazepine poisoning, always try to intubate the patient first. Even you don't put on the ventilator, just secure the airway, and it will decrease the chances of patient getting respiratory arrest. Similarly, we can see that these are the intubated patients, these are the non-intubated patients, and we have apnea spells here. And when we give flumazenil, things go smoothly. Even before giving flumazenil in an intubated patient, the things were going smoothly. So the main complication why patient dies or why a person dies is the respiratory failure, and that can be prevented simply by giving, or if flumazenil is not available, just secure the airway, things will be alright. Flumazenil can be given, it is a competitive and reversible inhibitor in GABA inhibitor, and always understand that the half-life of flumazenil is shorter, so resedation may occur after arousal. Coming to the antipsychotic, activated charcoal, yes, bicarbonate, yes, antidote probably none, benzodiazepine for seizure, hypertonic saline, maybe intraliquid if your QT prolongation is not reversing, and ECMO as the last hope. Lithium is one of the very important drugs which we need to manage in ICU. We do get a lot of psychiatric patients, they have suicidal tendency. In fact, it has been said that lithium itself increases the suicidal tendencies. So the drug which you give to revert the suicidal tendencies increases the suicidal tendencies. And we have a very narrow therapeutic index, even with the chronic user, just slight increase in serum level leads to the toxicity. And hemodialysis is the treatment of choice for lithium poisoning. It significantly decreases the plasma level and usually saves the patient. So indication, we have a plasma elevated concentration level threshold 6 to 8 for acute and 4 in chronic and 2.5 in chronic accumulated. And once the supportive treatment, primary supportive treatment is given, hemodialysis is the treatment of choice. Cyclic antidepressant, activated charcoal, yes, bicarbonate, yes, antidote, yes, benzodiazepines for seizure, hypertonic saline, maybe intraliquid, maybe if not corrected with sodium bicarbonate, ECMO as a last hope. SSRIs. SSRIs again the same thing, no antidote, but ECMO is a last hope. One important thing to consider here is the butapine as a SSRI. Butapine, which is very commonly used, and butapine poisoning usually causes significant QTc prolongation, and that things needs to be bear in mind. So may require ECMO as a last resort, but usually can be managed with soda bicarb or probably with the intraliquid. Coming to the party drugs are the we have alcohol, we have opioids, we have nicotine, ketamine, caffeine, ecstasy, amphetamine, cocaine, and magic mushrooms. These are the commonly drugs which have been used as a party drug. And again, I say it is not uncommon. We don't have such party culture like metro cities, but we do have party culture of bhang and Shivratri. We do get cannabis poisoning very repeatedly over this period of year. Alcohol, the main thing to consider here is hooch poisoning, and again every day, practically 3 or 4 times a year, we are hearing that in our nearby neighborhood only we get a hooch epidemic or hooch endemic, and we have a lot of people losing their lives. The problem with hooch is that due to improper fermentation, instead of ethanol, what they were consuming are methanol, and methanol causes severe metabolic acidosis, blindness, renal failure, and myocarditis, and finally death. So coming to the treatment of the hooch poisoning, supportive treatment, anti-convulsion, soda bicarb. Antidotes, we have a fomepizole and ethanol. I have never used fomepizole, never came across it, but ethanol, they are saying use equally good results, and Intermittent dialysis, of course, is the treatment of choice to increase the elimination. This is very interesting. We are not concerned more with the IV dosage of ethanol, but this is interesting. Oral dosage of ethanol, how we give, how we treat those who's poisoning. So basically, 40% that is vodka or we have a whiskey that can be given. So 120 ml to 150 ml initially, followed by 15 ml every hourly. So this is exactly those, if you have never known that, you can just remember it like this way. So this is the way this as antidote it needs to be treated. Fomepizole, I have never used it, or I said never came across, but this is the dose if you guys are interested. Cocaine. Cocaine is a white powder from coca trees. It is a powerful stimulant, very powerful stimulant. And if you are thinking that it's a Western country drugs, then you are mistaken, because just recently we had a cocaine of 5,000 crore from Ankleshwar, it's just in our backyard, what you can say. So it's very regular in India. Probably you can find it in every university and colleges. Those are not like our days where this was just a thing of Western society. Now we have it. It is basically inhibits reuptake of dopamine and powerful sympathomimetic and powerful stimulatory. Finally causes severely constricted blood vessels, causes myocardial infarction, causes stroke, everything. And it is usually taken in form of snorts. So whenever you come across cocaine poisoning, always remove any residual cocaine from the noses, and the treatment usually comprise of maintaining ABC, charcoal, and oxygenation. IV fluid prevent rhabdomyolysis. This is very important. Benzodiazepines for seizures and hypertension. Hyperthermia for cooling, soda bicarb for acidosis, SNP, sodium nitroglycerate, haloperidol, beta blocker, naloxone use carefully. Naloxone usually is not indicated here, but if there is a coma cocktail, if you, as a part of it, if you are using initially, then careful with this patient. Amphetamines, also known in as a layman term as a pep pills, and MDMA, also known as MD. And I bet you will find this MD in every other college or every fifth student in the university, and its poisoning is very, very common. And again I said, almost like 1800 crores of MD was busted. Gujarat ATS as multi-state drug operation, and this is happening in our backyard only. You might be having factories in Rajkot. Now again, I said that was a sympathomimetic drug and needs to be managed as per the management of cocaine. Roofies, what they call, is a strong flunitrazepam. It's a strong benzodiazepam. Remember the movie Hangover? That was the Roofies. And it causes it removes inhibition, causes memory loss. Victim is incapacitated, amnesic event, and it lasts longer. So probably that's why it comes as a day trip drug. And because of its short-term amnesia, but be aware, deep sedation, respiratory distress, blackout, respiratory failure, and death is not uncommon with the roofie poisoning. So coming back to our patient, finally we removed him from ventilator. He became conscious, and what he told was shocking. There was no herbicide poisoning. It was 110 tablets of lorazepam, 20 joints before everything, 20 joints at the same time, 110 tablets of lorazepam, 70 tablets of tryptomar, that is amitriptyline, and probably 100 tablets of tramadol, 50 tablet of pentoside. He was very nice, he don't want acidity to happen, and MDMA, that is MD. He don't know the exact amount, but he was sure that he had consumed MD. And probably what we are confident about paraquat poisoning, probably because of the tryptomar poisoning, or because of some dye used in this manufacture of this drug. Because of that we might be having. So this was the patient. What I have narrated was completely present in single patient, and this is the patient we received. Fortunately, this is the treatment certificate. Hemodialysis we did only once, and supportive care, ventilatory care, ICU care, iron antibiotic, soda bicarb we had given, antacid, supportive care. So everything what we described was given to this patient. You remember the sodium nitroprusside and what we had given sodium nitroprusside, NTG, Arcamine, isolazine, everything we had given. That was because of the hypertension what he was having. And two of the guys are sitting here. Vimal Somay, a psychiatrist, is not sitting here. So Vipul is there, Nankit is here. And he was finally discharged after 11 days. We extubated him after on the 7th day, and on the 11th day he was discharged. He was fine and still coming regular follow-up for his diabetes and everything. If we think, even in the far future, if we see, even in this post-apocalyptic world, this drug abuse is not going to go. I'm very clear about it. And this thing, drug abuse, may be very far from the reach or the grasp of social workers or our society. But for we intensivists, basically it is brutally near. We have an airway to secure, we have a heart to restart, we have a ventilator to manage, a to keep the flow, and probably and a family to counsel. So it's really near to us. And in conclusion, before I end my topic, it's very simple. Drug abuse and overdosing are very common. Gastric emptying methods are practically not proven. For cardiac toxicity, use soda bicarb, hypertonic saline, or intralipid can also be tried. Benzodiazepines for seizure, ECMO as a last resort, dialysis for lithium and methanol poisoning, that is food poisoning, naloxone for opioids, and flumazenil for benzodiazepines. Thank you for listening. Thank you very much.